Hello everyone, my name is Valentín García Gutiérrez and I'm working as hematology at the Hospital Universitario, Ramón y Cajal in Madrid, Spain. It's really my pleasure to be here today. And before we start, I would like to thank the ICML Foundation for giving me the opportunity to be here with you, discussing the nature and incidence of adverse events when managing our CML patients using TKIs. We are going to see during this presentation how is very relevant information that we always should take into consideration when treating our CML patients. By this moment, I'm absolutely convinced that all of you are aware of what we obtain with imatinib, but also with the probability of using some other TKIs and how TKIs dramatically improved the current prognostic of our CML patients. A very good example is this graphic that I'm showing from the imatinib, from the patient randomized to the imatinib arm with 10-year follow-ups from the IRIS study. I'm very sure that you all are aware that this is the study in which imatinib obtained its indication with. And we can see how those patients treated with imatinib, the overall survival is really very similar to the overall population. However, it's very important that we go in depth in the manuscript, and if we do that, we are going to see how around 40% of patients that were randomized to the imatinib arm discontinued treatment for whatever reason after 4 years of follow-up. So we can affirm that this nice graphic is not only thanks to the imatinib, but also thanks to the probability of rescue those patients that failed to imatinib. And that's the reason why treating CML patients is now so easy. It's not only a matter to give imatinib to everyone, and it's very important that we are all aware of and familiar with all TKIs that are currently approved for our CML patients. We can see how we have imatinib, 3 so-called second-generation TKIs, nilotinib, dasatinib, and bosutinib, and a third-generation TKIs. We can see how all the 3 second-generation TKIs plus imatinib are approved in the first line, and second-generation TKIs and ponatinib may be used in second or third line regarding patients' situation. When we have so many treatment available, in order to choose the best treatment for each patient, it's very important that we are familiar not only with indication, not only of how efficacious these drugs are, but also we need to be familiar with the safety profile. And this is what we are going to see during the presentation. As I previously mentioned, it's quite common that a patient is going to discontinue the first line treatment when they start with the TKI in first line. This is an example coming from the Decision study, which is the study that in which dasatinib obtained its indication within the first line. We can see how around 40% of the patients are going to discontinue treatment, and that there is not really, doesn't matter regarding if the patient starts with imatinib or dasatinib, because the probability of treatment discontinuation is quite the same. What is different is the reason why the patient discontinued treatment. If we go to the dasatinib arm, and this apply very similar to the rest of the second generation TKI, nilotinib and bosutinib, we can see how the most important reason for treatment discontinuation when we start second generation TKI in first line is going to be intolerance, side effects. In contrast, when we use imatinib in the first line, the most frequent reason for treatment discontinuation is lack of efficacy. However, around 1/4 of the patients are going to discontinue due to side effects. For those of you that may think that this is data from clinical trial and this data may not apply to our current clinical practice, if we take a look to what is considered the most important study in real life, the UTOS study that enrolled close to 2,000 patients and obtain very nice information. If we go to what happened to those patients treated in first line with imatinib, we can see how out of almost 2,000 patients treated with imatinib first line, around 30% of the patients with only a follow-up of 2 years we did discontinue treatment. And for those patients that discontinued treatment, the most frequent reason to do that was side effects. It's not only a matter of the first line, because unfortunately, once a patient discontinues treatment in the first line, it's quite frequent that the patient is going to need a second, third, or even fourth line. And if we take a look to what are the reasons why patients need third or fourth line, we could explain it with this data from this nice phase 1 study that some of you may be familiar with, the data, the phase 1 clinical trial with asciminib. In this trial, they showed what happened to those patients that were enrolled in asciminib and what was the reason why this patient did need a third or fourth line with asciminib. And if we take a look to the reason for TKI discontinuation, we can see how the most frequent one was intolerance, but also there was half of the patients that were considered failure due to lack of efficacy, but also intolerance. So intolerance is almost everywhere when a patient do need to treatment change for whatever reasons. So once we have seen how important it is and that a lot of patients do suffer side effects that even led to treatment discontinuation, the next question is, what are those toxicities that our patients are going to suffer when using TKIs, and also how frequent they are with whatever treatment that we are going to use. If we take a look to the kind of side effects, we can see that there are almost any kind of side effects that may occur with TKIs. And if we take a look to this BC slide, what I really meant with this slide is to show you that it may appear that the frequency of these side effects are quite the same for whatever treatment that we start with. But if we take a look in depth to this kind of side effects, we could differentiate two type of side effects. The first kind of side effect that is defined by the European Leukemia Act are those side effects that I'm showing here in green that are commonly grade 1 or 2, and they are not classified as a very important event for the patient, because most of them are well managed with treatment reduction, treatment interaction, or even some other current treatment concomitation. However, we need to take into consideration that some of these side effects may be chronic, and once they start to be chronic, this might have an impact in the quality of life of our patients. And if it has an impact in the quality of life of our patient, it may have also an impact in treatment failure, because these are patients that are going to keep some doses, or they are even going to go to treatment to dose reductions. It's very important to know that some of these side effects may be difficult to see for us as doctors, because some of these important side effects that are quite frequent are not side effects that we can see in a blood sample or by exploring our patient. This is a very nice study coming from the Italian group, in which we can see that a side effect as fatigues, muscle cramps, musculoskeletal pains are quite frequent even in patients that have been treated with imatinib for more than 3 years, and they were considered as optimal responders because they were at least in complete cytogenetic response. So these are kind of the best patient, but even in the best patient, we can see that they might suffer for this kind of side effects quite frequent, and it's important that we take it into consideration. Now the question is how we could manage these patients suffering from these persistent grade 1 or 2 side effects. We can see that we have commonly 3 ways to act. The first thing that we could do is to give the patient that symptomatic treatment. So to give diuretics in case of peripheral edema, supplemented with magnesium, quinine for those patients that have muscle cramps or muscle skeletal pain, loperamide for those patients who have diarrhea, or antiemetic. It is true that what we can do, and this is something that could be very, very efficacy, is to go for dose reduction. And we have nice data. This is the data that I showed came from the Destiny British study, showing how if we perform dose reduction in patients that are suffering from side effects, we are going to improve the quality of life of our patient. However, it's very important that we know that if we are going to consider dose reduction, the patient should be at least in an optimal response, because in case that a patient is not in optimal response, we can assume a risk of progression by reducing the dose in patients that are not in optimal response. So for those patients that are suffering from low-grade side effects, persistent, and are not doing well with symptomatic treatment, we do have information that changing treatment from imatinib from 2 second-generation TKIs could improve the quality of life of our patient and avoid these side effects. This graphic is from a clinical trial in which patients treated with imatinib with persistent grade 1, 2 side effects were changed to nilotinib, and we can see how most of the patients did improve the quality of life and avoid many of these side effects. However, there are some other side effects that are so-called off-target complications that is very important that we always keep on mind, because these side effects are not as frequent as we saw with previous side effects, but are for sure more dangerous. And are more dangerous because we are talking about side effects related to the cardiovascular system, heart and blood vessels, respiratory system, liver, or even pancreas. Fortunately, this, as I previously mentioned, these are side effects that are much less frequency but are more dangerous. The good news is that, as we are going to see, some of these side effects are considered to be almost specific to a specific TKIs, but also there are some situation from patients and comorbidity from patients that make patients more favorable to suffer from these complications. So in some way, what I'm trying to say is that it's important that we keep on mind the information that I'm going to show you in order to avoid potentially this kind of dangerous side effect by knowing the specific side effects that are related to a specific drug, but also what are the patients that have more possibilities to suffer from this important complication. And if we call about off-target side effects, what is really important to know that they are off-target because they are directly related to the mechanism of the drugs. We know that all TKIs were designed in order to inhibit ABL, but we are talking about protein kinase inhibitor, and they do not inhibit only ABL, but also they inhibit some other kinases. And the inhibition, as we are going to see, the inhibition of these kinases that we see they differ from one drug to another are the reason why we are going to see specific side effects. If we talk about off-target side effects, it's very important that we talk about cardiovascular events, because these are one of the most frequent adverse events that we are going to see with TKIs, but also it's very important because they are quite dangerous. Because when we talk about cardiovascular events, there are different cardiovascular events, but there are some of them which are called the arterial occlusive events that are potentially dangerous. Because when we talk about these arterial occlusive events, we are talking about ischemic heart disease, ischemic cerebrovascular disease, and peripheral arterial occlusive disease. If we take the incidence of these adverse events in total with imatinib, nilotinib, dasatinib, and ponatinib, we can see how in total, when we treat our patient with whatever second generation TKI, the probability of suffering this cardiovascular event seems to be superior to imatinib. However, among all the second generation TKIs, the highest frequencies is with nilotinib, and the highest frequency with all kind of TKIs is with ponatinib. We can see how almost 30% of the patients that were treated in the PACE study suffer from these arterial occlusive events. If we talk about cardiovascular events, it's very important to know that it's not only a matter of the drug. There is also a matter of some other problem that the patient may suffer that could facilitate the probability of suffering this kind of adverse events. And this is, for example, what we can see from the NEST-ND study that I'm very sure you are all aware that this is a study in which nilotinib obtained its indication with. Totally, the probability of suffering arterial occlusive event for those patients treated with nilotinib in this study was close to 10%. However, we saw that around 80% of the patients that suffered from this cardiovascular event were classified as high risk for cardiovascular risk profile. So we can see, for example, that for those cardiovascular events before 5 years of follow-up, the incidence of these cardiovascular events was much different between those patients that were categorized as low risk from Framingham score, intermediate, or high risk from Framingham score. This way we can see how the incidence in those patients low risk was 2%, that increased to almost 15% in those patients high risk. Same information after 5 years. Total incidence for those high risk classified by Framingham was more than 30%, and only 8% for low risk by the Framingham score. A very similar and nice study was performed by the Italian group for those patients treated with nilotinib. They showed how the incidence of cardiovascular events was really related to the risk, cardiovascular risk factor of the patient that were treated. And they came with this score, which is quite easy to assess. They take into consideration only the age, the gender, the total cholesterol, and the systolic blood pressure, and the smoking habit. And we can see that for those patients that were classified as low risk, none of the patients suffer from arterial occlusive events, and close to 30% of those patients that were classified as high risk. So it's important to classify, as we are going to see, our patient in terms of cardiovascular risk factor in order to avoid this kind of drug for those patients that are in high risk. But in the other hand, it's very important that we keep in mind that if a patient is not considered as a high risk for these cardiovascular events, we can give whatever drug quite safe. We do not specifically know the mechanism why these cardiovascular events are related with nilotinib, but what we know is that by using nilotinib, our patient, in some percentage of patients, are going to suffer from hyperglycemia that may be important, grade 3 or 4, and hypercholesterolemia. And we know that hyperglycemia and hypercholesterolemia are classically considered as an important prognostic factor for using cardiovascular events. So it's very important that when we start treating our patient with nilotinib, we measure and we follow the hyperglycemia and hypercholesterolemia and treat this cardiovascular risk factor. As I previously mentioned, the highest probability of suffering arterial occlusive event is with ponatinib. And we kind of know the mechanism why ponatinib has been related with arterial occlusive event. And it's due to the inhibition of VEGFR. We know that VEGFR is a receptor that are expressed in the base and endothelial cells. And the inhibition of the receptor has been related not only with ponatinib, but with some other kind of TKIs that do inhibit the receptor has been related to the possibility of suffering cardiovascular event and arterial occlusive event. And it happened with nilotinib, the highest probability of suffering from cardiovascular events for those patients treated with ponatinib was related to the cardiovascular risk factor. And we can see how in those patients treated with ponatinib in the phase 2 PACE study, an important prognostic factor was hypertension, previous ischemic heart disease, diabetes, or hypercholesterolemia. And most of the patients that suffer from these cardiovascular events, once they were treated with ponatinib, they were considered before they started with ponatinib as a high cardiovascular risk patient. It's very important that we know how to mitigate this incident of cardiovascular events, because we know that ponatinib is at this moment the best strategy to rescue those patients that are resistant to second generation TKI. And it's a very important and very efficacy drug. So it's very relevant and very important that we use ponatinib in the best way. And this is very nice information that has been recently published from the OPTIC trial. The OPTIC trial is a study in which the patients that were resistant to second generation TKIs started ponatinib in 3 different arms. They started with three different starting doses: ponatinib 45 milligram, ponatinib 30 milligram, and ponatinib 15 milligram. Which is very important is that all the patients that were treated with 45 and 30 milligram, they decreased the dose once they achieved optimal response. And we can see how performing this ponatinib dose adjustment, the total incidence of arterial occlusive event, even for the highest dose, the 45 milli starting dose, decreased to less than 10% compared to the 30%. If we compare what happened in the PACE study compared to the OPTIC study, we can see how the incidence of arterial occlusive event really diminished dramatically by selecting well our patient, but also performing dose reduction once our patient obtained optimal response. So as I previously mentioned, before we start a TKI, it's very important that we assess the cardiovascular risk for our patient. There are some or many recommendations on how we should perform this evaluation. Was test we should perform baseline, but also what is very important is that we perform a cardiovascular risk follow-up right after they start and we start the treatment, because it's very important that we focus in the blood pressure, the glucose, the lipid. We perform echocardiogram, electrocardiogram, and this recommendation may differ in terms of they are treated with some TKIs that may be related to higher incidence of cardiovascular events. So arterial occlusive events is not the only cardiovascular event that have been related with TKIs. Another classical and typical cardiovascular event is the pleural effusion that happens for those patients that are treated with dasatinib. And this is also could be related to the unique inhibition by dasatinib of PEGFR and SRC. And this is these kinases are have been seen that are the inhibition is more potent with dasatinib compared to the rest of TKIs. Totally, the incidence of pleural effusion when a patient is treated with dasatinib is around 30 milligrams, but there are some risk factors that have been identified that are related to the incidence of pleural effusion, as older patient, previous heart failure, or autoimmune disorder. There are some strategies that may be performed in order to mitigate, to go down for this incident of pleural effusion. And we know that is related to the dasatinib dose, but also to the plasma levels. This is a very interesting and very nice study from the French group in which they showed how by measuring dasatinib plasma level, they can dramatically reduce to less than 10% the incidence of cardiovascular events compared to those patients that they do not monitor the plasma level. They went out more than 30%. So it's very important the plasma level of dasatinib that our patients are going to have in order to know what is the probability of suffering from this important complication, and it is the pleural effusion. But to measure a plasma level may be difficult for many of us, and probably an easier do that we can do in order to avoid this pleural effusion is to give lower dose of dasatinib. And this is a very nice study from the MD Anderson, in which they compare data from 2 different clinical trials from patients that were treated with dasatinib in first line with 2 different schedules, 50 milligrams and dasatinib 100 milligrams. And they showed us how the incidence of cardiovascular event was dramatically reduced with less than 5% for those patients that were treated with dasatinib 50 milligrams. And they also showed how this dose of 50 milligrams was enough in terms of efficacy. Probabilities of achieving optimal response was very similar with the dose of 50 milligrams compared to the 100 milligrams. So this is a strategy that we could take into consideration, especially for those patients with higher risk of pleural effusion, as could be older patients. How to manage this pleural effusion? Well, it's important to early diagnostics, treatment, dose reduction, and treatment interruption until this complication is resolved. There is some recommendation to use some steroid or diuretics. It's very important to know that once we see a patient with pleural effusion, the probability of suffering recurrence is in around 60% of the patients. So if we see a pleural effusion in one patient, we should think in changing treatment, because the probability of suffering another pleural effusion is quite frequent. And it's very important to know that the incidence of pleural effusion in the first line is not very frequent with bosutinib, but we don't know very well the reason why. But once a patient suffers from pleural effusion, if treated with dasatinib, the probability of recurrence, if we go to treatment change to bosutinib, is more than 50%. So bosutinib is not the best treatment option for those patients that suffer from pleural effusion with dasatinib. There is also another complication that has been related to dasatinib, as it is hypertension, pulmonary hypertension. We need to know that this is a very rare adverse event. Is suffering in less than 1% of the patient, but it has been related to dasatinib, and we need to take into consideration, because this is a very dangerous complication. So we always need to keep in mind that this is something that is very infrequent, but they might be related to dasatinib. Some other toxicity that may be more frequent with some TKIs compared to another are the liver toxicities. In general, we can see how liver toxicity are more frequent with whatever second generation TKI, especially with nilotinib and bosutinib. We can see how the incidence of liver toxicity is all grades is around 20%. Is around could be more than 50% with nilotinib. The good news is that it's very uncommon that these toxicity are going to be grade 3 or 4. However, by using bosutinib, we need to take keep an eye on these liver toxicities, because even grade 3-4 liver toxicity may be as frequent as 20% when using bosutinib at the dose of 500 milligrams, which is the dose that is recommended in the second line. If our patients suffer from a liver toxicity, especially for grade 3-4, we need to hold the drug until the toxicity is resolved and resume a lower dose. If our patients suffer from a grade 4 toxicity, probably the best thing that we can do is to perform to treatment change to another TKI that has not been related with high probability of liver toxicity. Pancreatic toxicity is another side effect that is important that we take into consideration. This problem has been seen more frequent with nilotinib and with ponatinib. It could be quite frequent that we could see an increase in this pancreatic enzyme, the amylase and the lipase, and does that not really mean that the patient are going to suffer from a symptomatic pancreatitis. But if we see an increase in this pancreatic enzyme, we should, especially if they are grade 3 or 4, we should stop the drug until they resume and restart at lower dose. We have to keep into consideration that the highest probability of suffering pancreatitis has been seen with ponatinib. Another toxicity that could be related to one drug is the diarrhea that we commonly see with bosutinib. When we treat our patient with bosutinib, the probability of suffering from diarrhea is around 70 to 90%. The good news is that this diarrhea is commonly very well managed with symptomatic treatment, and in clinical trials, the probability of treatment discontinuation due to diarrhea was less than 1%. And that means that this is an adverse event that is almost always recovered once if we treat the patient correctly and we interrupt the treatment, and we could also give our patient to prophylactic loperamide. So in conclusion, there are many adverse events that are related to TKIs, and they are frequent. We need to pay attention and manage them because they might impact in the quality of life and therefore in treatment response. There are some specific adverse events that are related to a specific treatment that could be dangerous for our patients. So it's very important that we know what are those adverse events related to whatever TKIs, but also that to know what are those patient comorbidities that could facilitate the incidence of these adverse events in order to avoid them. And always our intention is to give the best treatment option for a specific patient. And to do that, it's very important that we take into consideration the patient comorbidities when choosing the best TKI for a specific patient. Before I finish, I would like to do it showing this paper from the European Leukemia Net recommendation, focusing in the management and avoidance of adverse events related to the TKIs. Many of the information that we have seen during this presentation came from this important paper that was led by our Spanish colleague, Dr. Stigman. So I really hope that this presentation was of your interest. Thank you very much once again to the ICML Foundation for giving me this opportunity.